Hey guys, it's Miss Jumper. We're going to cover chapters 67 and 68. I'm going to do two separate videos so they're shorter chunks to watch, but I'm going to get these chapters done and uploaded for you guys so you can watch them over the weekend, and we can do some more fun activities in class to reinforce the learning. So chapter 67 is what this video is going to be, so I'm going to share my screen and get started. Okay, so cerebral vascular disorders, these occur when we have blood supply to the brain that's disrupted in some way or fashion, and there's different ways that can occur. Stroke is our primary cerebral vascular disorder and is the 5th leading cause of death in the United States and a leading cause of like prolonged disability as well. All right, so what are some modifiable risk factors for stroke? So there's modifiable and non-modifiable. Oh my gosh, I'm having a stroke. Modifiable risk factors. Hypertension is a primary risk factor. That one definitely can be controlled and modified, right? Cardiovascular disease, atherosclerosis, elevated cholesterol, hyperlipidemia, obesity, diabetes, use of oral contraceptives for women, and smoking and drug and alcohol. So those are all ways we can modify our risks for a stroke. Non-modifiable risk factors are age, so you can't control how old you are. Male genders are more at risk, and then African American are more at risk for strokes. So what is a stroke? You may hear, lay people call it a brain attack or a stroke, but I think there's been lots of education that's been done to the public in the last 20 years. So I think everybody's pretty familiar when you say a stroke and they know what that means. But basically, it's a sudden loss of function that results from a disruption of the blood supply to a part of the brain. And the cells begin to die after a certain amount of time when you don't have any blood flow to them. So the brain cells, they're real persnickety and they like their blood flow and their oxygenation. So even within 5 minutes, the brain cells can start to become affected. So we have two different types of strokes. You can see here, this ischemic stroke is where we have a thrombus in one of our cerebral arteries. And this is 87% of strokes are ischemic. So this is the more common type of stroke that you'll see. And so basically we've got a blockage here, and then wherever is past that blockage is not going to be getting blood flow, and we're going to have ischemia and tissue death of those brain cells. And then our hemorrhagic stroke, this is about 10 to 15% of our strokes. And this is where we have a vessel actually rupture. So you can see this vessel rupture, and then we have bleeding into the brain. So it spills out around the brain instead of supplying the brain with the tissue. So not only do we have no blood flow to that area, but then we also have problems with bleeding, putting pressure on the brain. And we'll talk about that more in just a little bit. So ischemic stroke, we have the disruption of the blood supply caused by an obstruction, which is a thrombus or an embolism that has caused blood flow to that area to cease. So blockage of the blood flow can either be from an embolus, so a clot leaves a part of the body, let's say the heart, which cardiac condition is really common for causing these little microemboli or these little clots, AFib, right? Because the atria just quiver, right? And blood pools in there, and then clots can develop. So that's why it's really important that we have our AFib people on blood thinners and prevention for that. But they can travel and get lodged in a cerebral artery and block flow to that portion of the brain, and then again cause tissue death. Or we can have narrowing or stenosis, and you can kind of see that in this picture. So this is a diseased carotid artery. So it's got the atherosclerosis, and remember we were talking about this in cardiac. This is the buildup of fat and cholesterol and substances within the arterial wall. This is plaque, and then it can restrict blood flow. And then remember, plaque can burst, and this triggers that blood clot cascade, and we can develop a clot around that ruptured plaque. So it's considered normally a heart problem when people hear of atherosclerosis, but you can have it in any artery. So it could be in cerebral arteries as well. So this can cause ischemic stroke as well. Transient ischemic attack, a TIA. I'm sure you guys have probably seen this or heard of this. So we have some sort of blockage to prevent blood from getting to the brain tissue, but it's typically either temporary or not a full ischemia, not a full blockage. So what's the difference? It's not a full-blown stroke yet, but they're going to have signs and symptoms of a stroke, and these can last for a few minutes to hours, but then resolve. This is usually a warning sign of an impending stroke, and so we're going to do a diagnostic workup to find and see if we can prevent a stroke from occurring. And usually with these TIAs, we have people that have plaque in their carotid arteries. So they'll do ultrasound of their carotid arteries, and it'll tell us how much flow they have, or stenosis of those arteries as well, because we could have stenosis of those carotid arteries from the plaque buildup. So that is a TIA, basically. So I'm sure you guys have all heard of FAST. So how do we detect a stroke? And there's been lots and lots of education on this to the public. So most people are kind of familiar with how this goes, but as a nurse, how do you perform this assessment? So the National Stroke Association came up with this education that's been pushed out to the public over the last 10 years. And I think people are really familiar with how to do this, even for a family member. So that's good because it can save their life. So face, if they have facial drooping, so we can have them smile and see if their face droops on one side when they smile. Arms, you want them to hold both of their arms up like this, and if one arm drifts, that'd be their affected side, so that's a sign of a stroke. Speech, ask them to talk, have them repeat a simple phrase. Does it sound slurred, or is their speech not making sense of they can't follow that command, or maybe they don't speak at all when you ask them to. And then time. So we need to note the time of like when the symptoms initially started, and we need to call 911 because the quicker you can get them into the ER if they're a candidate for TPA, then we need to get that started right away. TPA has to be given within a 3-hour window of the onset of the symptoms of the stroke. So it's really, really important that if any of these symptoms present, that the patient comes to the ER right away. So let's talk a little bit about remembering our brain anatomy and which areas of the brain control different daily processes for us. So this is important when we're talking about patients who've had strokes, because depending on the area of the brain that they've had a stroke in is going to be the deficit that we'll see with the patient. So in our parietal lobe, this controls our sensation, language, perception, our sensory area, so skin sensations like temperature and pain. The occipital lobe is primarily vision and color perception. And then our temporal lobe is hearing, language, and memory. And specifically language comprehension, or you'll hear this called this little spot right here in the temporal lobe Wernicke's area. So Wernicke's has to do with language comprehension, and we'll talk a little bit more about that in a few slides. And then we have the cerebellum, and this is responsible for posture, balance, and coordination movement. And our brainstem controls really important stuff, so our consciousness, our breathing, and our heart rate. So that's really important. And then remember, depending on the side that the injury occurs, if we have a cerebrovascular event on the right side, which side are we going to see affected by that? So the right controls the left side of the body and the left controls the right. So if we have a stroke on the right, the left side's going to be affected. And if we have a stroke on the left, the right side's going to be affected. So always remember it's opposite. So if you're getting a report and, you know, someone saying, hey, this person's had a right hemisphere CVA, then you can expect your patient to come up and have a left-sided effects from that stroke. So just keep that in mind. There's a chart in your book. That's a really good one that I'd like you guys to look over, and I put it in the reading guide as well, but the neurological deficits of stroke and manifestations. And then it has another column that lists nursing implications, so things you can do for people who have these deficits. That's really important for you guys to know. So I want you guys to read over that, and you need to be familiar with these terms, because when you see these questions on the NCLEX, you're not going to be able to grab your Tabors or whatever dictionary, and being able to know what these terms mean is really going to be indicative of how you're able to answer those questions. So hemiplegia, so this is paralysis on one side of the body or part of it, and this is caused by damage on the opposite side of the brain. So just like we talked about, right versus left. The hemiparesis, or weakness on one side of the body or part of it. Dysarthria, so this is difficulty in speaking, or dysphagia, which is impaired speech caused by paralysis of the muscles responsible for producing speech. And then we have aphasia, which is unable to speak. And this can either be a comprehensive problem or a production problem. So expressive aphasia is the inability to express oneself. So I can comprehend what you're telling me, but I can't get out what I want to say back. And this occurs in the Broca's area. And then the receptive aphasia is the inability to understand the language. So think receptive, like I can't receive the message you're trying to give me. My brain is not receiving that message. So you may say, this is a pen. And I'm like, I don't know what you just said. My brain can't interpret what you're telling me. And this happens in the Wernicke's area. And you remember where I showed you that on the previous slide. And then you can have a mix or global aphasia. And this can be a mix of expressive and receptive. Apraxia is the inability to perform voluntary movements, even though the muscle function is normal. So your brain just is not getting that signal to your muscles to tell them, hey, move. Right. The hemianopia, which is blindness in half of the vision field in one or both eyes. And this affects the side of vision that corresponds with the paralysis side of the body. So if it's a right stroke, it'll be the left eye or the left field of vision that's affected. And with these patients that have this, we want to always approach them from the side where they can see and not the injured side. And put things in their visual field that they can see on. Agnosia is the loss of ability to recognize objects. So I'm like, tell me what this is. It's a Taco Bell cup, and I don't recognize what that object is. So that's agnosia. Dysphagia, difficulty swallowing. So I just want you guys to be familiar with these terms. So what are some treatments? Carotid endarterectomy is a pretty common one. Always tell my patients that it's a roto-rooter. So they go in and basically unclog your drain. It's a really easy way you can explain to them, you know, what it is. But the main surgical procedure is, this is for TIAs and mild strokes, is this carotid endarterectomy, because this is where they're having that TIA come from, because the carotid artery is blocked with plaque. So they go in and basically remove the plaque, the atherosclerotic plaque or thrombus. It's important after this to do neurochecks, notify immediately the physician if you see any changes in neuro status or deficits develop, because this means a new thrombus could have formed and they'll need to go back in and perform the procedure again. And then we want to check the dressing for swelling and drainage, because they can have a hematoma form at the site. Okay, so medical management of a stroke. So what's the first diagnostic tool that we do when someone comes in with stroke symptoms? We do a CT, a non-contrast CT. And why do we do a CT first before we do an MRI? Because what we need to figure out is what type of stroke it is. Is it ischemic or hemorrhagic? So when we do a CT, we're ruling out a hemorrhagic stroke first, because if the stroke is hemorrhagic, then the patient is not a candidate for TPA. So if we get that CT back and we don't see any bleeding on the brain, then we know that we likely have an ischemic stroke, and then this patient could receive TPA as long as they meet the other criteria. So later on, we can get an MRI, and this will show us the lobe and the area of infarction of the ischemic stroke. But we want to do that CT first, because we've got to rule out whether it's hemorrhagic or not. And then TPA, so let's talk about that a little bit. So this dissolves the clot and activates protein that causes fibrinolysis. So it's going to break down the clot for ischemic stroke. And you can look at chart 67.3. That's a good chart in your book that has a description of that. When giving TPA, I want you guys to highlight this or mark this down or write this down and take a note of it. Write it down. When giving TPA, you give 10% as an IV bolus over 1 minute, and you give the other 90% of your dose over the next hour. So just be aware of that. So if I was given a dose of 100 milligrams, I would give 10 milligrams IV push, and then I would give 90 milligrams in a bolus. In an IV piggyback. So this can only be given within that 3-hour window of the onset of symptoms. So that's why it's really important for us to get a time of when those symptoms started. We have to get a CT scan, like we said, to make sure there's no bleeding. We're going to check and make sure our labs are within normal limits. So glucose, our platelets, things like that. Our blood pressure has to be in a tighter control. So if their systolic's greater than 185 or their diastolic's greater than 110, then we need to give some antihypertensive meds to keep them within those parameters. They can't have been on heparin or anticoags. No head trauma or recent surgeries for GI bleeds, because anything that is going to increase their risk for bleeding, and we're giving a med that stimulates fibrinolysis, so we don't want to cause a major bleed. For a patient that's received TPA, we want to monitor for bleeding. We want to do neuro checks around the clock, and this is your NIH stroke scale. So basically what we're wanting to see is an improvement or a reversal of their symptoms as the TPA starts to work and dissolve the clot. So we're going to be doing these, this NIH stroke scale, and we want to see it get better. A score of 0 is no stroke signs, and a score of 21 to 42 is severe signs of stroke. So, of course, we're going to get a baseline and see where they're at when they came in, but then we're going to complete this, and we want to see that get back down to hopefully 0 if the TPA is successful. But table 67.4 in your book has another picture of this NIH stroke scale that you can look at. It's good for reference. We need to manage their blood pressure again. We want to keep it in those parameters. These patients who've had TPA absolutely cannot fall. A fall for them would be devastating, life-threatening injury. So we've got to make sure that these TPA people don't fall. No IM injections. We want to avoid unnecessary sticks, in that immediate period after. So keep those things in mind if you ever have somebody who has received TPA. So let's talk about communication in a patient with a stroke. So we said there were some different types of communication deficits. So let's talk about receptive. So those who were unable to comprehend, how can we better communicate with those patients? So we want to speak clearly, and we don't want to speak in a rushed tone. Sometimes we get really busy and we go in and, blah, 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 we just start spouting off stuff. Well, somebody who already has a problem comprehending is not going to be able to understand if we're speaking really, really fast, right? We want to use short, simple phrases and simple details, and we want to allow time for the patient to process what we're saying. So we can't ask them a question and then 2 seconds later, if they haven't answered us, expect them to come up with an answer. They're going to need time to process that. So give them a minute or two to think about what it was that you just asked them. You can use words, simple words and gestures. So if, I'm telling them, hey, let's get up to the bedside commode, and they don't understand what I'm saying, I can point to the bedside commode, like this is where we're going, sit. I can use gestures, drink, eat. So there's certain things that if they can't understand the spoken word that we can use, and then they're like, oh, okay, that's what they're asking me. With our expressive communication, they can comprehend, but they have trouble speaking. And this can be super frustrating for them because like the words are in there and they don't come out like they normally do, like they want them to do. So we need to really be patient, let them speak, and don't finish their sentences for them. It's really easy to be like, oh, you're saying, hand me your water pitcher. Is that what you're saying? Try to let them get out what they can get out and be patient. It can be really frustrating for them when we're speaking for them and trying to fill in their sentences. We need to ask simple questions one at a time, and usually questions that are a simple response. Yes, no, things like that are going to be easier for them to respond than tell me how that makes you feel. So that might not be the appropriate response for that person. Communication board, we want to, this is something that we can use when we're going in and talking or trying to talk with these patients that have the expressive problem. So we can, we use these a lot on our unit when we have stroke people, but you can, we have like these are dry erase, and we can take it in and they can either point to it or circle it. We have like a little pen that they can do. So if they're having trouble getting their words out, then they can, they can point to drink, hot drink, cold drink, food, help, pain. So they can point to these different things, or shower, slippers, teeth. So, and these vary, just depending on, what company you buy them for or what things are on there. Yes, no, tired. So there's different things that they can point to that help them communicate. And on the back side of it, it's just a simple dry erase board that has you can just write with a pen on it. It's just a blank dry erase board. So if they want to write out words, they can. So those are just some different tips when we're trying to communicate with someone who's had a stroke. So be very patient. That's the key to communication. Okay, so a hemorrhagic stroke is caused by bleeding in the brain tissue, the ventricles, or the subarachnoid space. So we have a couple processes here with hemorrhagic stroke. It can either be blood supply to the brain tissue is interrupted because the artery is ruptured, right? Or we can have blood leaking out around everything. And you remember in my last lecture when we talked about the skull's inflexible and can only accommodate and fluctuate to a certain point to keep the pressure normal. So now that we have a brain bleed and it's causing increased intracranial pressure within that subarachnoid space. So we've got two problems. We've got a ruptured vessel and we're not getting blood supply to that area that it was supplying. And now we have blood bleeding out around our brain in that subarachnoid space that is causing increased intracranial pressure. So we have compression or secondary ischemia from reduced perfusion and vasoconstriction caused by that injury. So what are some things that can cause hemorrhagic stroke? Brain aneurysms, so weakened or bulging of the arterial wall. So that it just bursts and bleeds out. And then uncontrolled hypertension. So we have so much force of the blood to the brain that it can weaken the arteries and cause them to rupture. So this is what we get worried about when we have that patient come in and their blood pressure is 240 over 180. The pressure is just so high, and the cerebral arteries are so small, and they can only take so much pressure, and then they can rupture and they can have a hemorrhagic stroke. So your signs and symptoms are going to be similar to ischemic stroke, but hallmark signs are severe headache that signals a rupture of an aneurysm, or early and sudden changes in LOC. So like talking to you 1 minute and then just completely change the next. And vomiting. So treatment, bed rest with sedation to prevent agitation and stress. And stress causes vasospasms, so we don't want that. Surgical interventions are not normally done unless our deficits are severe, but they can do evacuation of the clot with a craniotomy. If bleeding and on anticoags, so if they were on anticoagulants, so somebody had a hemorrhagic stroke and they were on, heparin or Coumadin or those type of things, we can give fresh frozen plasma and vitamin K because we want to stop that anticoagulation process. And then these type of strokes are any kind of brain injuries at risk for seizures, but especially hemorrhagic stroke. So seizure precautions, and then we want to monitor electrolytes. All these brain injuries are at risk for electrolyte imbalances, specifically hyponatremia. And we'll talk a little bit about that in the next chapter. So man, I went through that really quick. I think that is like a showstopper for me, a record. That's all I have on this one, and I'm going to record the next one and get these both uploaded for you guys to watch over the weekend.